Please welcome EASL Secretary General, Professor Laurent Castira, on stage.
Good afternoon. It's my pleasure to welcome you to the International Liver Congress in Amsterdam. This year again, we have 9,574 attendees from 127 countries. Not surprisingly, many attendees come from Europe, above 5,000, Asia, Africa, North America, Latin America, and Australia and South Pacific. Again, amongst the top 10 countries, US comes as first with 1,300, followed by the UK, Germany, Italy, France, Spain, China, Netherlands, Belgium, and Switzerland. We received 2,576 abstracts, of which 1,682 were accepted, 172 as oral, 1,510 as poster. As for the lead breaker abstract, we received a record number, 130, 52 were accepted, 12 as oral, 40 as poster. I want to take this opportunity to thank the reviewer for the hard work they have been doing and without whom this meeting could not happen. And I would ask you to give them a big applause. This year's honorary president is Professor Howard Thomas from London. He's a well-known figure in viral hepatitis. He was at the Imperial College. He was a Sherlock Fellow and co-worker. And he was also a member of the scientific committee. And this is a very nice painting from Professor Thomas that was done live yesterday night by a French artist, Mr. Zapata. This year we have 3 EASL recognition awardees, as usual. Georgina Mieli-Vergani from the UK, very famous pediatrician. Gustav Baumgartner from Austria, seminal work in cholestasis. And Kenjiro Wake from Japan for discovery of stellate cells. We also have 2 EASL Young Investigator awardees, one from the UK, Evalija Liasco, and one from France, Jean-Charles. Among the highlights of the meeting, we have 2 state-of-the-art lectures. The Jean-Pierre Benamou, the clinical one, entitled Liver Transplantation for the Treatment of HCC, given by Vincenzo Mazzaferro from Italy, the father of the Milan criteria. On the basics, the Kampf-Wilhelm von Pfupfer lecture on mechanism of evasive resistance in HCC, given by Mike Hall from Switzerland. Among the other highlights, we have the fusion hepatology session. This will be devoted to the global view on Hep C on Saturday, and we'll hear speakers from Europe, US, Egypt, India, and Japan. You all, at least many of you, attended the previous session, and I'm very proud to show you the printed copy of the clinical practice guideline, the updated HPV clinical practice guideline, chaired by Pietro Lambertico. And I want to take this opportunity to thank Pietro for the fantastic work he has been doing and also for the panel. Thank you again. On Sunday, we have also the presentation of the guidelines on acute liver failure chaired by Julia Wendon, on PSC joined with ESG with Lars Abaken as chair, and on primary biliary cholangitis by Gillian Hirschfield, and this we present on Sunday. On Saturday, we'll have also discussion, not updated yet, on HCV guideline chaired by Jean-Michel Pavlovsky. And I want to take also this opportunity to show you the EASL HCV Advisor app. This is a way to use the guidelines at the bedside. It comes for free, either as iOS or Android. It will be made available for download tomorrow, Friday, starting midnight. And this should be helpful to tailor according to your patients and to your need at the bedside the use of the guidelines to treat your patients. Last but not least, most of the research is presented as posters. As you know, we keep the paper format, but we also have e-poster. And for the first year, we have an in-house management, and you have noticed that EASL managed your poster from the start to the end, printing your poster, and also displaying your poster and changing them every day. I hope you will appreciate this new service provided by EASL. I also want to thank the sponsor, without whom this meeting would not be possible, of course. But as you know, EASL is not only ILC, it's much more than ILC. Our flagship journal, the Journal of Hepatology, under the leadership of the editor-in-chief, Rajiv Jalan, the three co-editors, Thomas Berg, Jessica Zuckman-Rossi, Ramon Batailler, and the senior editor, Richard Moreau, and also all the associate and special section editors. Not only it has an impact factor above 10, not only publish high-level scientific papers, but also clinical practice guidelines. This is what professional medical organizations should provide to its member. And we have published already 25 EASL CPG so far, and there are many other in the pipeline. And as I already mentioned, we just published, and these are available in paper copy. You can go to the booth to take them: management of HBV, management of acute fulminant liver failure, diagnostic and management of patients with PBC, and role of endoscopy in PSC. In the pipeline and coming soon, decompensated cirrhosis, revised alcohol liver disease, revised hepatocellular carcinoma, nutrition in liver disease, hepatitis E, and drug-induced liver injury. These are to come. Another priority of my mandate has been to strengthen the partnership of EASL at the scientific and educational level by enhancing collaboration with sister societies, including ASLD, APASL, and ALE. And you remember that last year we signed here with WHO the Joint Society statement for the elimination of viral hepatitis, and this materialized by the publication in the 4 society journal of this manifesto. Also, we have run several joint events, including the EASL-ASLD Special Conference on Hepatitis C in Paris. It was a big success with over 800 attendees. ASLD EASL HBV treatment endpoint workshop was also run in Alexandria last September, and I'm very proud to announce that a position paper is in press and will be soon available in GF and Hepatology. Last but not least, we also have the EASL-ASLD definition, therapeutic advances, and clinical endpoints in alcoholic liver disease and alcoholic hepatitis that will be held in London this September. We also collaborated with our friends from Asia, from APASL. We recently ran a joint symposium on pathogenesis and histopathology of NAFLD in Shanghai during the annual meeting, and we are also running during this meeting a joint workshop on landscape of HCC in Europe and Asia. And with our friends of HALE from Latin America, we had the best of EASL at their meeting in Santiago in September 2016, and we'll run the Best of Valle and ISL in Bogota next month. Last but not least, ISL also is partnering with UEG in Brussels to strengthen the synergy around EU policy activity and for lobbying for liver disease at the European level. And I think this is very important to speak from one voice. Another priority of my mandate has been to reformat the educational offer, and we have launched an open call for 2018 monothematic and school, as you already know. We want more online education using e-tools that you already know, such as the Liver Tree, more than 20,000 users with the iLiver, and also open access content, including online grand rounds and topic and conference debrief. And I want to take this opportunity to thank our two educational counselors, Francesco Negro and Massimo Pinzani, for the fantastic job they've been doing. This year in November in Rome, we will run the first NAFLD summit called the Target-Oriented Approach to Diagnosis and Pharmacotherapy of NASH, a dialogue between academia and industry. We also introduced a new ISL school format, and we will shift from the traditional model, the teacher-centered, content-oriented, where passive students are beneficiaries of the learning process, to a flipped model, the learner-centered, problem-oriented, where active students are elaborating a solution to a given problem. This is the flip model. A pilot has been run in Geneva with Francesco Negro, and another school will be run this year in November in Madrid in Spain. Of course, ISL also is involved in advancing research, and we have also reformatted under my mandate the ISL Fellowship with new format and better funding, 60,000 € for the postgraduate fellowship, the so-called Shella. We have also implemented the PhD studentship that is named after Professor Juan Rodez, a giant in hepatology that unfortunately passed away this year, and this fellowship is named after him. We also have the short-term training fellowship, the Andy Burroughs, and the Daniel Alagil Award that start from this year. Now, of course, we're looking at the future, and the future of our specialty lies in the end of the future generation, the young investigator. This also has been one of my priorities when I joined the ISL board 5 years ago. I was chair of the Young Investigator Concerted Action Group, and one of the first actions was the creation of the masterclass. And this was 4 years ago. We have run 4 masterclass already and other events during the meeting. And I'm very happy to announce that this year in December in Paris, we'll run a joint ISL ASTLD masterclass. So please apply. Last but not least, we have created the ISL International Liver Foundation last year with Professor Colombo as chair. Can we show the foundation?
There's one thing everyone on this planet has in common. We are all different. The way we look, the way we live, our hopes and dreams are all individual and unique. We know that a healthy liver is an essential part of a rich, full life. And that's where you are uniquely placed to be a positive part in the life of anyone and everyone, everywhere. When we find new cures, eliminate disease, restore health and extend life, we bring joy and hope for a better future, not only to patients, but to everyone around them. To do this isn't always easy, and no one can do it alone. But when you're backed by people you trust, real experts in their field, people with skills, people with passion, people who are committed to giving everything it takes to push the limits, and suddenly everything becomes possible. That's why we created the International Liver Foundation, to give you the funding and support you need to make a real difference, to transform lives and change the world. Introducing the ILC International Liver Foundation. Behind you every step of the way.
May I call Professor Colombo on stage? The Foundation has decided to give a €2 million check to the foundation.
Lower. Thank you so much, Mr. Secretary General, for this first step. Good afternoon, everyone, and thank you so much, Laurent. As you heard, the International Liver Foundation has been created by ILC just to fulfill some unmet needs that came along in the very last years. Particularly, the aim of this foundation will be to heighten and boost campaigns of awareness, meaning that we want to go in the community to increase and widespread the knowledge about the risk of having chronic liver disease and how to prevent and treat them, but also within the small community where already exists the knowledge and the awareness that there is disease, trying to overcome the barriers that have been generated in the last very few years that prevent proper and effective management of the clinical conditions. And in the 2018 agenda, we have already started producing video clips to expand, to heighten awareness regarding hepatitis C, B, and metabolic disease, why not alcohol disease, to be delivered in the commercial malls, in the transportation centers like airports, and also the soccer stadiums, if you wish. And this will probably translate in increased awareness among the general population. The 2018 agenda also includes the development of programs, exchange programs, aiming to deliver education in areas of the world which are outside the borders of Europe, meaning Far East, Middle East, Africa, and South America, where on the top of the classical educational courses based on clinical case discussion, delivering of state-of-the-art and all our practical guidelines, we wish also to expand program of exchange based on preceptorships for young hepatologists to be invited to spend a period of time in selected centers for liver transplantation in Europe, and also to visit for a couple of weeks at least the centers that are considered to be top hospitals dealing with the issues of cancer, portal hypertension. Last but not least, the foundation is aiming also to fundraising with the aim to boost and to fund research, and we elected to prioritize research programs based on regenerative medicine, with the ultimate goal to materialize a dream, which could be, why not, a bioartificial liver. While doing so, we hope to generate not only knowledge, but also to generate funds enough to to sustain research in the many labs in Europe and abroad that are now confronting and challenging the target of successful regenerative medicine-based medicine and therapies. May the 2nd, there will be a meeting in Paris at Institut Pasteur that will act as a chaperone to create a kind of a consortium among top scientists that involves scientists from UCL, Yale University, and the Aga Khan University, plus other centers in Europe, with the aim of starting, it will be a kind of a kick-off meeting to start an agenda program to deliver research and science in the area of regenerative medicine with the ultimate goal of an artificial liver. I do hope that the program will be successful. We need, of course, to start a campaign for fundraising, and I think that if we will be successful, we can really back all these initiatives in the years to come. Thank you very much for your attention and help.
Thank you very much, Professor Colombo. Last but not least, as you know, I will step down at the end of this meeting, and I've been very proud to serve the community. And of course, leading a professional medical organization like ISL is a teamwork. And I want to thank the ISL Governing Board. It's been a pleasure to work with you. I think one of the most fantastic memory of my career is building up the ILC program. So I think you deserve a big applause for what has been achieved. I want also to thank personally Professor Carlsen, who will become Secretary General and without whom it would have been impossible to achieve what we have done, and also that has been instrumental in setting up the foundation. So please give a big applause to Professor Carlsen as well. This is the ISL office, the people behind the scene, and they have a great part in the success of ISL. And I want also to thank the ISL office under the leadership of Grégoire Poivillon. The Congress is organized for the 3rd year in-house, and again, I would like to give them a big applause. Thank you very much for your attention. This is now time for science. I want to thank the sponsor before concluding, and I want to mention that next year the ILC will be in Paris. See you next year in Paris. Thank you very much for your attention.
It's a pleasure and an honour to be the honorary president for this meeting. And I thank Laurent and the governing body for doing that honour. We're a little bit behind time, so we need to move immediately on to the programme. Could I ask Richard Morrow to come to the rostrum to present his paper on a randomised trial of 6 months fluoxetine therapy in patients with Charles Pugh class 3 cirrhosis. Okay.
It's not the good one. Okay, I could speak about defining a CLF in you know, but I think we should move to the next speaker, and I will correct this. Sorry, it's not my fault.
Well, the next speaker is Concierge from a series of institutions. And he'll be talking on multi-center randomized trial comparing short-term stenting versus balloon dilatation for dominant strictures in primary biliary cirrhosis. And this is from institutions in Amsterdam, Stockholm, Italy, Sweden, and in the United Kingdom.
Okay. Thank you, Mr. Chairman, ladies and gentlemen. Good afternoon. I'd like to start with thanking the organisers for inviting me to present our data on the DIL-STENT trial here today. The DIL-STENT trial was a multi-center randomized trial comparing short-term stenting versus balloon dilatation for dominant strictures in primary sclerosing cholangitis. These are my disclosures. As you may know, about 50% of PEC patients during the course of their disease will develop one or more dominant strictures, and the annual incidence was estimated around 9% in a successive series of endoscopic surveillance from Heidelberg. And in patients with increasing cholestatic complaints and a rise in alkaline phosphatase or bilirubin of at least 50%, the chance that they will have a dominant stricture is about 60%. Now, dominant strictures were more or less arbitrarily defined by Adolf Stiel from Heidelberg almost 15 years ago as a narrowing to 1.5 millimeter or less in the extrahepatic ducts, or a narrowing of 1 millimeter or less in the left hepatic or right hepatic duct, of which you see a number of nice examples in this advanced case of primary sclerosing cholangitis. Now, whether this translates into how a patient feels, functions, or survives, in other words, if it's clinically relevant, is not well established, but what we do know is that patients who do have symptoms and a dominant stricture is found upon ERCP, which is treated, for instance, by stent treatment in our series from about 20 years ago. This is associated with a marked and significant drop in cholestatic complaints such as pruritus, fatigue, cholangitis, and right upper bottom pain, associated with a 30% or more drop in cholestatic biochemical parameters such as conjugated bili, alkaline phos, and gamma GT. And this led the joint ESGE-ESOL committee, who produced recent clinical practice guidelines on endoscopic therapy of PSC, to state that ESGE-ESOL suggests performing endoscopic treatment in PSC patients who present with symptoms likely to improve following endoscopic treatment. Strong recommendation, however, low quality of evidence. However, which form of therapy to dilate strictures is the best is completely unknown. One could revert to balloon dilatation, which was the predominant form of treatment in the successive endoscopic surveillance by the Heidelberg group, and from that series one could infer that 2-year recurrence-free rate is about 30%, whereas we found in our respective series employing short-term stenting, 1 or 2 weeks stent, and then take it out, a recurrence-free rate of about 70%. And this led us to hypothesize that short-term stenting is superior to balloon dilatation, and therefore the aim of our trial was to compare single-session balloon dilatation versus short-term stenting with regard to efficacy and safety. And to this end, we recruited non-end-stage LASIK PSC patients with a Child-Pugh score less than 8 and a Mayo risk score less than 2 in 9 centers across Europe, who experienced either of the following entry criteria: bilirubin, which rose to 3 times the upper limit of normal, or an increase in cholestatic complaints plus a 50% increase in alkaline phosphatase or bilirubin recently, or a more than 20% recent increase in alkaline phosphobilirubin, together with a documented stricture on MRCP or diagnostic ERCP within the last 4 months, an increase in cholestatic complaints with a documented stricture, or some cholestatic complaints score more than 3, or moderately severe pruritus or right upper colon pain plus a documented stricture, and a dominant stricture, of course, which was deemed amenable to both modalities of ERCP by the treating endoscopist, upon which patients were randomized during ERCP. And this shows a graph, a table of the Amsterdam semi-quantitative scoring of cholestatic complaints, which is a ordinal score ranging from 0 to 4, none to intolerable, and knows 4 domains: pruritus, fatigue, cholangitis, right upper colon pain, and it's very easy to apply. As co-primary endpoint, we have the cumulative recurrence of recurrence-free rate of the dominant stricture in patients without experiencing an initial failure, and at secondary endpoints, one of the main endpoints was safety. Now, initial failure was defined as an assigned treatment failure or a dropout for procedure-related complications such as cholecystitis due to blockage of the cystic duct by a stent, for instance, or an alkaline phos or bilirubin which failed to drop by at least 30% at the 3 months initial failure assessment, or an alkaline phos which failed to drop below 80% plus no improvement in cholestatic complaints score at 3 months visit. And we needed that assessment of the response of alkaline phos and or bilirubin to help us in our decision rule for re-ERCP. Because ideally, in a trial which assesses the effect of a dilatory therapy, you would want to perform a cholangiography every 3 months for the next 2 years, but for obvious reasons that is not feasible. So we had to design a decision rule to point out which patients would be eligible for re-ERCP. And this decision rule consisted of the same criteria, more or less the same criteria which led to entry into the trial. So patients who entered the trial because of an elevated bilirubin higher than 3 times the upper limit of normal were eligible for re-ERCP when upon follow-up the bilirubin returned to its baseline level. Patients who had a sufficient decrease of alkaline phosphobilirubin but then returned with these levels to their baseline values and had an increase in cholestatic complaint scores of at least 1 point relative to the previous visit were eligible for re-ERCP and bouts of cholangitis. Now, in these cases, patients were subjected to re-ERCP when the dominant stricture was back. This was an endpoint, and when the dominant stricture was had not recurred, then a patient was censored. The follow-up time was 24 months. We assumed that the efficacy of stenting was about 60% versus 30% of single session balloon dilatation, which led to an estimated necessary sample size of 84 patients. So for allowing for some dropout, we wanted to recruit 100 patients. Now, after a planned interim analysis by the Data Safety Monitoring Board, recruitment into the trial was stopped prematurely because of futility and a disproportionate occurrence of serious adverse events in one of the groups. So in the end, we had 80 patients that were assessed for eligibility. During ERCP, 15 dropped out because there was no dominant stricture, or the stricture was deemed not amenable to both treatment modalities. So we had 65 patients that were randomized, 31 to balloon dilatation and 34 to stent. In both groups, 1 patient did not receive any treatment at all. So these were excluded from the safety analysis, and the primary outcome was assessed according to the intention to treat. These are the baseline characteristics, which are more or less similar in both groups with regard to demographic factors and factors like UDCA use, previous sphincterotomy, median, baseline bilirubin, etc. And this is the main slide. Here you see the results of the Kaplan-Meier curves of the recurrence-free rate. In green the stent and in blue the balloon, and they are almost completely overlapping with a p-value of 1.0 in the log rank test. And also with regard to initial failure, there was no difference between the two groups. Now, when looking at procedure-related serious adverse events, which were defined as any event that occurred within 30 days of randomization, requiring hospitalization or prolongation of hospitalization, patients were kept overnight after the procedure and was deemed at least possibly related to the procedure. Those were classified as procedure-related serious events, and these occurred much more frequently in the stent group, 45% versus almost 7% in balloon dilatation group, with a high odds ratio and a very low p-value. And the relative risk of having a procedure-related serious adverse event in the stent group versus the balloon group was almost 7. And as you can see, it was mainly driven by post-ERCP pancreatitis. So when we then looked in a univariate and multivariate logistic regression for potential confounders such as age, sex, disease duration, concurrent IBD, UDCA use, prophylactic NSAIDs, center, previous sphincterotomy, all sphincterotomy during the procedure, all randomization. Randomization was the only one that was found significantly associated with procedure-related severe adverse events, both in the univariate and in the multivariate analysis. And when doing a sensitivity analysis only on post-HCP pancreatitis, the same pattern was seen. Only randomization was associated significantly in the univariate analysis and showed a trend in the multivariate in relation to the occurrence of procedure-related adverse event. Of note, previous sphincterotomy, which is the best protection factor for the occurrence of post-HCP pancreatitis, was seen in the whole group, so irrespective of randomization status, in the patients who had previous sphincterotomy. Pancreatitis was only seen in 4% as opposed to 20% in patients who did not have a previous sphincterotomy with an odds ratio of 0.70, which trended to significance with a p-value of 0.07, which, Mr. Chairman, leads to the conclusion in this first ever randomized trial of endoscopic therapy in PSC. I think it's fair to conclude that the recurrence-free survival of balloon dilatation and stenting is equal. However, stenting is associated with a much higher occurrence of procedure-related severe adverse events. So we think and we feel that in patients, PC patients with dominant strictures, with an intact, especially in those with an intact papilla, balloon dilatation should be the first treatment of choice. And with that, I'd like to thank all the collaborators throughout Europe of the STENT study group, the Norwegian PSC Foundation for its financial support, and you for your attention, and I'm happy to take questions.
Well, we're running a little late. I think we've got a minute to take a couple of questions. Please come to the microphones and give your name before you speak.
Hello. Hi, I'm Carlos Cardenas from Barcelona. Thank you for your study. Very interesting. I have one question. Did all patients receive post-ERCP prophylaxis for pancreatitis, or did they receive any rectal indomethacin or anything that would prevent pancreatitis, and was this equal between both groups?
Yes, about 70% of the patients received NSAIDs prior to the procedure. That was depending on the local custom in the center. And we found no relation whatsoever with the occurrence of post-HCP pancreatitis.
Thank you.
Microphone 3.
This is 5.
5, sorry.
Okay. That's my confusion, sorry. Everson from Colorado. It seemed that if you had a prior sphincterotomy, you were somewhat protected from the pancreatitis that occurred with stenting. But on the other hand, if you had an intact papilla, as you suggest, stenting was associated with a high rate of pancreatitis. Is the high rate of pancreatitis due to a new initial sphincterotomy performed at the time of stenting? Because with balloon dilation, you might not be doing sphincterotomy, but with stenting, you typically do.
Well, in Europe, many centers, and also we do not perform routine sphincterotomy upon placing the stent. That's one thing. And especially with regard to this same question, we did this multivariate logistic regression where sphincterotomy during the procedure, all previous sphincterotomy did not come out as a factor influencing the risk of adverse event, and especially post-HCP pancreatitis.
So it's more the long-term exposure to the foreign body. Do you think that's the factor related to pancreatitis?
Yes, or maybe, well, what we know, what you often see in these patients is they have very small and retracted papillas.
I think you need to continue this outside, actually. We're running terribly short of time. Thank you very much for the presentation.
Now we move to the next presentation that is come from Germany, from the group of Heine-Meyer, entitled Interferon-Free Cure of Epstein-Virus Das Alter, the Soluble Inflammatory Milieu which could affect hepatocellular carcinoma surveillance by CD8 plus T cell in patients with liver cirrhosis. And the presentation will be given by Dr. Sekiere.
So, thank you for the introduction, and thanks again to the EASL Scientific Review Committee for giving us this opportunity here in the General Assembly. I must say that we are really honored. So first, I show you the disclosures of my clinician co-authors. That is me, nothing to disclose. So it is now pretty clear that interferon-containing therapy actually led to a reduced incidence of hepatocellular carcinoma in S3R patients. Now, HCV is undergoing a therapy revolution with the new interferon-free DAAs, with tremendous cure rates often exceeding 95% of patients. But still, HCCs do occur. Late last year, our Spanish friends here raised a red flag about an even earlier and more frequent occurrence of HCC in patients who receive interferon-free direct-acting antiviral therapy. And ever since, this has become a subject of hot debate with so much contribution from so many countries in Europe. And today, we present you data also from our cohort in Hanover, which you can have a look at during the poster session. And please bear in mind, the number is 081. Visit it. Now, if you put these data together, what the overall summary is actually heading towards is that there is probably no incidence of an increased de novo HCC, but then the data on the HCV recurrence is still conflicting. So in envisaging the potential mechanism that would cause an earlier than expected HCC in patients who receive DAAs, we actually focused on T cells, which are very important in immune surveillance of HCC. Last year, we showed in a paper that was published by Julia Hanks from our group that in patients who have chronic hepatitis C, there is an alteration of the soluble inflammatory milieu compared to those with NASH and also to the general population. So here, what you can very well imagine is that these increased cytokines and chemokines would cause an activation of your T cell activity in a way to contain the spread of the virus, but also in so doing inhibits the proliferation of these cancer cells. So now you give these patients DAAs and you abruptly take away the virus. It is expected that the inflammation will also reduce, T cell activity would be compromised, then cancer cells would have a field day to proliferate. So this is what shaped our hypothesis that interferon-free direct-acting therapy for HCV would induce dynamic changes in T cell responses, which would then affect HCC progression in patients with cirrhosis. And to help us address these, we came up with three principal questions. The first one being whether there is an alteration in the inflammatory milieu in these patients with advanced cirrhosis. And if there is, what is the effect? Or can we detect HCC-specific T cell responses in these patients with advanced cirrhosis? And if so, what is the effect of therapy in this setting, especially in patients who would receive the DAAs? So to attempt to answer the first part of the question, we recruited 24 patients with advanced cirrhosis, all of whom received DAAs and achieved SVR. Out of the 24, 17 remained sane without any HCC development. 7 of them actually went on to develop HCC, but at baseline, no clinical parameter was significant between them. And here we also included 10 healthy individuals as controls. In these patient cohorts, and also in the healthies, we analyzed serum concentrations of 50 inflammatory mediators by luminous assay. And this is the first plot, which is represented here as a principal component analysis plot, where we saw that there was a very clear and distinct classification of the healthy individuals and the patients with baseline cirrhosis. Again, what was also very interesting for us, especially regarding this data, is that the patients that had baseline cirrhosis but then received therapy and then got HCC were also more clusterized. And as you can see here, there were more inflammatory mediators which were upregulated, especially IL-12, interferon alpha, and such like being important for T cell activity. So we asked, are these upregulated cytokines so much important for T cell activity at baseline? This is what we investigated next in a serotic cohort using non-serotic controls of chronic hepatitis C and healthy individuals. So from these patients and the healthy individuals, we isolated PBMCs and stained the PBMCs with CFSC, which is a fluorescent dye, and on top of that stimulated these with peptides which are known HCC-associated antigens. And what happens is that the cells which recognize the peptides and proliferate would have daughter cells springing up that would have reduced amount of CFSC. So the decrease in CFSC intensity can be used as a proliferative marker. So what we saw was that, please bear in mind that these are patients with no tumor at baseline, the serotic cohorts, no tumor at baseline. But still, for both CD8s and CD4s, we could detect very robust proliferation, and this was also very broad across all the pools that we analyzed. Apart from proliferation, we also analyzed cytokine production, where directly we stimulated cells with the HCC-associated antigens in a 10-day culture and did ICS, intracellular cytokine staining, for interferon gamma, MIP1 beta, and TNF. Again, for all these cytokines here showing you only interferon gamma, there was robust production in the serotic patients compared to the non-serotic controls. So now, we asked, are these baseline proliferation and function of the T cells so important for cancer development? This is what we investigated here by delineating the patients who developed HCC from those that did not. And what we did here was that we analyzed their T cell responses at baseline, or if you like, therapy start. What we could clearly see was that in the patients that developed HCC, there was a reduced proliferation of CD4 and CD8 T cells. Not only that, cytokine production was also significantly reduced. So our next question then was, what about the serotic cohorts with robust T cell proliferation and function? If these patients receive therapy, what would then happen to these T cells? And this is what we longitudinally studied by sampling PBMCs at therapy start, end of therapy, and also at follow-up. And again, we studied T cell responses. What I'm showing here is a representative fact plot from one patient, and I'm only showing you data from only 2 pools, so that it will be very clear. So first, when you do not stimulate the cells, you don't see any proliferation. But at baseline, upon stimulating the cells with these HCC-specific antigens, we see robust expansion. At end of therapy and follow-up, these responses are completely waned. And I must hasten to add here that this was not a universal phenomenon, because there were also conditions whereby the vice versa responses were also true. But overall, when we summed up the data, we could clearly see that at end of therapy and follow-up, the decline of T cell responses was significant. Not only did this happen at the proliferation level, but then cytokine production also by interferon gamma, MIP1 beta, and TNF were all significantly declined at end of therapy and follow-up. On top of these, markers of T cell activation in vitro, such as CD38 and PD1, were also declined at end of therapy and follow-up. So everything I've shown you up to this point is the global T cell responses to overlapping peptides of GPC3. Now we wanted to see whether this is replicated at the epitope-specific level. Staying with our serotic cohort, but this time only focusing our attention on those with an HLA2 allele, we sampled PBMCs again from baseline, end of therapy, and follow-up, stimulated the cells with very well characterized HLA2 restricted peptides here in a 10-day culture, and this is the data. Very similar to what I've shown you before for the GPC3 proliferation. Here again, when we stimulated with the single peptides, we could see robust expansion at baseline, especially for this epitope for one patient. At end of therapy and follow-up, this response was completely abrogated. This is also another epitope showing that this does not occur with respect to only one epitope. So overall, what I've been able to show you is that serum concentrations of various soluble inflammatory mediators are altered in patients with cirrhosis. The HCC-specific T-cell responses are readily detectable in these patients, but for the patients with baseline cirrhosis that developed HCC, these responses were really weak. And finally, DAA therapy for HCV significantly decreases the strength of CD8 T cells, but not so of CD4s, which I've not shown because of the time, in these cirrhotic patients. So finally, as a result of this impact of DAA therapy on HCC surveillance by CD8 T cells especially, we want to suggest that a close HCC screening is recommended in cirrhotic HCV patients with HCV clearance. Finally, I would want to thank the big group here in Hanover, my PI, Heiner Wiedemeyer, and also Markus Komberg, and to SFB 900 and SFB 738, where we get our financing from. Thank you very much for your attention.
Thank you very much, Dr. Sikire. This paper is now open for discussion. We have time for 2 questions. Please go to microphone 3, 4, or 5, otherwise we cannot see you. Jordi. Can we have microphone 4?
Hello? Now it's okay? Yeah. If I understand well, you suggest that there is a decrease in the immune control of potential HCC clones. It is known that the cancer that appears today is there months or even years ago. So if the immune surveillance goes down, you think that there is a peak of cancer emergence associated in time with DAA treatment, thus supporting what we published in Recurrence? Because the discussion goes about if HCC is accelerated and appears associated in time, or if this is not modified and the incidence is exactly the same. So what do you think? Because the opinion of you and your group is relevant. Is the alarm there or not?
For this, I mean, from this data, I cannot really draw any hard and fast conclusion on whether this is really of extreme importance. That is why our suggestion is that a longer follow-up should actually be done to look at these dynamics. But again, moving in that direction, what I've shown you before was in the cirrhotic patients who did not develop any HCC, not in those that developed HCC. For those that developed HCC, the data is still preliminary and we are still validating it, but then we see that the T-cell responses that I showed that are weak at the baseline come up, and this might coincide with some elevation of maybe cancer markers like AFP and such, but we are still validating that, and that is why we are not. I don't know whether that really answers your question.
We have time for one more question. Microphone 5, Antonio Bertoletti.
Yeah, thank you. My question is like this. You have tested only hepatocellular carcinoma specific T cells. So did you test some other T cell response to see whether what you find as a modifications of T cell function is really specific only for hepatocellular carcinoma T cells or for other T cells? Okay,
thank you very much for that, Sue. I think the genesis of this probably might be what happens to HCV that has already been published. It's still under debate whether it increases or not. So for in this direction, we also measured T cell responses for HCV specific T cell responses. But in this non-cirrhotic, very severely sick patients, we do not see any such restoration as has been reported.
So the modification is only specific for hepatocellular carcinoma T cells?
Yeah, so if I can have, so this is the data for the HCV. Again, this is the antigen-specific T cell expansion on the left, and also cytokines. Here we don't see any restoration, so it's really specific for...
I'm afraid we have to go on to the next paper now. We're ready for Richard Morris.